welcome to the deep dive. I was looking back at the news from 2002, and it's actually kind of wild to think about.
Oh, it was absolute chaos.
Right? A single medical study comes out, and millions of women around the world literally just threw their medication in the trash overnight.
Yeah, because the headlines were just screaming that hormone replacement therapy caused breast cancer.
It was a total media frenzy.
Yeah.
But what if I told you that nearly 2 decades later, the long-term follow-up of that exact same study quietly proved that for many of those women, taking those hormones actually reduced their breast cancer mortality rate by 40%.
I mean, it is arguably the most consequential reversal in modern preventative medicine.
Right.
And it barely made a blip in the mainstream news cycle.
Which is just crazy to me.
It really is. The conflicting narratives over the last 2 decades have left, an entire generation of women terrified, confused, and just suffering through debilitating symptoms because they firmly believe HRT is a guaranteed path to breast cancer.
Okay, let's unpack this. Because if you were sitting there trying to make a decision about your own health, the sheer volume of contradictory data is just, well, it's paralyzing.
It's completely overwhelming, yeah.
We are looking at a massive stack of literature today, decades of clinical trials, huge meta-analyses, and some brand new predictive genetic modeling from the Institute of Cancer Research. We really need to figure out why the headlines are always so terrifying, and crucially, what the biology and the statistics actually mean for you.
To really understand the modern fear, we have to dissect that 2002 bombshell.
The Women's Health Initiative.
Right, the WHI.
Yeah.
It was this colossal randomized clinical trial following over 27,000 postmenopausal women. And, the sheer scale of it gave it enormous authority.
Which makes sense. I mean, that's a huge sample size.
Absolutely. But the way the initial data was communicated to the public fundamentally warped our perception of risk.
Because the press basically treated all HRT as one singular thing, when in reality, the WHI trial actually had 2 completely different groups taking entirely different drug regimens.
Exactly. You had one group, women who had previously had a hysterectomy, and they were taking estrogen-only therapy.
Yeah.
And then the other group, women with an intact uterus, were taking combined HRT. So that was estrogen paired with a synthetic progestin.
And this distinction is where the biology becomes really crucial.
It changes everything. If we fast forward to the 2020 long-term follow-up of this exact same cohort, they tracked these women for over 20 years. And the data from the estrogen-only arm is just astonishing.
What did they find?
Well, taking estrogen alone, specifically a formulation called conjugated equine estrogens, it resulted in a 22% lower incidence of breast cancer compared to the placebo group.
Wait, let me stop you right there. Because the mainstream narrative has completely drilled into our heads that, estrogen fuels breast cancer.
Yeah.
How does taking an estrogen pill lower the incidence?
What's fascinating here is the underlying mechanism. It's a biological process called apoptosis, which is essentially programmed cell death.
Programmed cell death. Okay.
Yeah. So when a woman goes through menopause, her body is deprived of its natural estrogen, right? If there happen to be dormant microscopic breast cancer cells present, they also become estrogen deprived.
Oh, I see where this is going.
Right. So the prevailing biological theory is that when you suddenly introduce a steady, high dose of estrogen back into that deprived environment, it actually triggers apoptosis in those specific cancer cells.
It overwhelms them.
Exactly. It causes them to die off before they can even form detectable tumors.
That is incredible, and it wasn't just fewer tumors forming either. The data showed a 40% lower breast cancer mortality rate in that estrogen-only group.
Yes. They were less likely to get it and significantly less likely to die from it. Wow.
But we do have to look at the other arm of this study, right? The women taking combined HRT, because they were taking that same estrogen, but with a synthetic progestin called medroxyprogesterone acetate added in.
Right. And the addition of that synthetic progestin really changed the outcome. In that combined HRT group, the 2020 data confirmed a 28% higher incidence of breast cancer compared to the placebo.
So, yes, more women were diagnosed.
They were, but, and this is a massive caveat that literally never makes the tweet-length news updates, there was absolutely no statistically significant difference in breast cancer mortality.
Meaning more cancers were detected, but taking combined HRT did not actually increase a woman's likelihood of dying from breast cancer compared to women taking a sugar pill.
Precisely, because breast cancers diagnosed in women taking HRT often tend to be, well, lower grade, less aggressive, and caught earlier.
Got it. But of course, detecting any cancer is traumatic. which is why the medical community continually tries to weigh this data against other studies.
Which brings us to the counterweight.
Right, because just as the WHI data was being reevaluated, The Lancet published this massive meta-analysis in 2019. The Collaborative Group on Hormonal Factors in Breast Cancer. They pooled data from dozens of studies, looking at over 100,000 cases.
Yeah, huge undertaking. And their conclusion was really aggressive. They stated that all systemic HRT increases the risk of breast cancer and that the risk lingers for more than 10 years after you stop taking it.
And drug regulatory bodies reacted immediately to that, didn't they?
Oh, instantly. They mandated new safety warnings based on the argument that risk is entirely duration dependent. Like the longer you take it, the higher the risk, completely regardless of the formulation.
But I have to push back heavily on the methodology of that Lancet study, because when you dig into the critiques, particularly from the British Menopause Society, there's a glaring flaw in how they set up their baseline control group.
Oh, the baseline issue is huge.
Right. The Lancet researchers basically compared the breast cancer risk of early menopausal women taking HRT to age-matched women who are already postmenopausal and not taking HRT.
Which, fundamentally skews the comparative risk.
Exactly, because early menopause naturally lowers your risk of breast cancer simply because your body is exposed to less of its own natural estrogen over your lifetime.
Right.
So comparing a 50-year-old on HRT to a 50-year-old who has been completely estrogen depleted for years, I mean, it artificially inflates the difference between them. Like testing a new running shoe speed against people who are walking rather than other runners.
What's fascinating here is that analogy perfectly highlights the issue. The British Menopause Society argued they should have compared those HRT users to age-matched, normally cycling women, women whose bodies were still producing natural hormones.
That would give a true reflection of the risk of simply extending a woman's natural hormonal state.
Exactly. The baseline you choose completely dictates the relative outcome. It's almost an epidemiological sleight of hand, whether intentional or not. But beyond the control group debate, the Lancet study forces us to confront a much bigger issue in how we process medical information. It highlights this massive, often terrifying gulf between relative risk and absolute risk.
Here's where it gets really interesting. Because the way our brains process statistics is just fundamentally flawed.
Oh, completely.
When that Lancet study dropped, the headlines blared that taking combined HRT increases your risk of breast cancer by a third. If you are a woman weighing this decision, hearing increase by a third sounds like a massive looming threat. Your brain imagines a 33% jump in danger.
But we really need to translate a third into actual human lives. Let's look at the absolute baseline math provided by that very same Lancet study.
Okay, let's hear the math.
Take a group of 50 women of average weight who are not taking HRT. Just due to normal background risk, genetics, environment, 3 of those 50 women are expected to develop breast cancer between the ages of 50 and 69 anyway.
Okay, so 3 out of 50 is the baseline.
Right. Now, if those exact same 50 women decide to take continuous combined HRT for 5 years starting at age 50, that number goes from 3 expected cases to 4 expected cases.
Wait, so an increase of a third literally just means one single extra case per 50 women over a 20-year period.
That's exactly what it means. It is a microscopic shift in absolute reality, packaged and sold as a massive, terrifying percentage.
It is like buying a second ticket for a mega lottery.
Yep.
You have technically doubled your relative chances of winning, a 100% increase in your odds. But your absolute chance of holding the winning ticket is still just infinitesimally tiny.
That analogy perfectly captures the distortion. And to truly ground that absolute risk, we have to contextualize it. The British Menopause Society did a brilliant breakdown comparing the risk of 5 years of combined HRT against everyday lifestyle factors that we rarely panic over.
Let's hear those numbers, because this is definitely the aha moment.
According to the data, taking combined HRT for up to 5 years causes about 8 to 10 extra cases of breast cancer per 1,000 women. Now, compare that to alcohol. Drinking 6 or more units of alcohol a day, which is about 2 large glasses of wine, causes an estimated 11 extra cases per 1,000 women.
So a couple of glasses of wine a day actually carries a higher statistical breast cancer risk than combined HRT.
It does, and postmenopausal obesity carries a roughly equal risk, causing an estimated 10 extra cases per 1,000 women.
But we never see terrifying news alerts about a glass of wine.
Yeah.
And doctors rarely tell patients to suffer through debilitating hot flushes because they might drink a Chardonnay.
Yeah.
Why do alcohol and fat tissue increase the risk so much?
It really comes down to cellular mechanics. Alcohol directly increases the levels of estrogen circulating in the blood, and simultaneously, it impairs the liver's ability to clear that estrogen out of the system.
So it creates a sort of toxic buildup.
Exactly. As for obesity, fat cells actually contain an enzyme called aromatase, and aromatase converts androgens, which are male hormones that women also produce, into a type of estrogen called estrone.
Oh, wow. I didn't know fat cells produced estrogen.
Yeah, so even after the ovaries stop working, postmenopausal obesity creates this constant, uncyclical estrogen drip directly into the tissues, which obviously stimulates breast cell proliferation.
Which perfectly explains the biology behind those lifestyle risks. And once we realize the absolute risk of HRT is essentially comparable to carrying a few extra pounds or enjoying wine with dinner, it completely defangs the panic.
It really does put it in perspective.
But we can't just lump all combined HRT into one bucket. The sources make it glaringly obvious that the specific formulation you take changes the math dramatically.
We absolutely have to talk about the progestogen difference. Remember, if you have a uterus, you must take a progestogen alongside estrogen to protect the uterine lining from thickening and potentially developing endometrial cancer.
Right.
But not all progestogens behave the same way in the breast tissue.
The WHI trial used medroxyprogesterone acetate, right? Which is a synthetic progestin.
And that synthetic nature is the key here. Synthetic progestins are molecularly altered so they can survive digestion and metabolism. But because their shape is slightly different, they don't just bind to progesterone receptors.
What else do they bind to?
Well, they can act like rogue keys, fitting into other locks in the body, binding to glucocorticoid or androgen receptors. In breast tissue, this crosstalk triggers distinct cellular proliferation pathways, driving up that cancer risk.
But there is a modern alternative that doesn't do that. The massive French E3N cohort study looked at women using micronized progesterone, which is bioidentical. It is molecularly identical to the exact hormone a woman's ovaries naturally produced before menopause.
Right. Because it is an exact match, it fits the body's progesterone receptors perfectly without triggering those rogue off-target pathways.
And what did the study show?
The E3N study showed that using micronized progesterone, or a similar formulation called dydrogesterone, alongside estrogen for up to 5 years does not increase the risk of invasive breast cancer.
That is a staggering distinction. If you choose micronized progesterone, that already tiny absolute risk practically evaporates for those first 5 years.
It really does.
And while we were talking about how hormones enter the body, we need to clarify the route of administration for women who aren't using systemic patches or pills.
Oh, absolutely. Vaginal estrogen is a totally different conversation.
Right. If you are using low-dose vaginal estrogen, like a cream, a tablet, or a ring, to treat local genitourinary symptoms like severe vaginal dryness or recurrent UTIs, the data is entirely unanimous. There is zero increased risk of breast cancer.
None whatsoever. Vaginal estrogen is designed to be absorbed locally into the vaginal and urethral tissues. The amount that actually makes it into the systemic bloodstream is so phenomenally low that it essentially keeps a woman circulating estrogen at normal postmenopausal baseline levels.
So it doesn't move the needle on breast cancer risk at all.
Exactly. It doesn't move the needle one bit.
But even with all of this reassuring data on bioidenticals and absolute risk, there is one major fear that stops women in their tracks: genetics. The question we always hear is, what if breast cancer runs in my family? Doesn't that act as a multiplier?
It's a completely valid fear, and thankfully we have new predictive risk modeling from the Institute of Cancer Research that integrates family history specifically with HRT use. It puts real numbers to that fear.
Walk us through the model. What happens if a woman with a strong family history takes HRT?
Let's look at a woman with a genuinely strong family history. Her baseline risk of developing breast cancer by the time she turns 80 without ever touching a single hormone pill is already high. The model estimates it at 19.6%.
Okay, almost 20%.
Now, if that same woman decides to take 5 years of combined cyclical HRT starting at age 50, her risk goes from 19.6% to 22.4%.
So her lifetime risk increases by 2.8% in absolute terms.
Yeah.
It goes up, yes, but it doesn't double. It doesn't skyrocket to 50%. It is a modest bump on an already elevated baseline.
If we connect this to the bigger picture, The predictive model was built to prove that short-term HRT use to manage debilitating symptoms only modestly increases risk, even in high-risk categories.
That is hugely reassuring.
It gets better. Even for women with BRCA1 or BRCA2 genetic mutations who represent the highest possible genetic risk, the data is surprisingly reassuring. If a BRCA carrier undergoes a risk-reducing oophorectomy, meaning she has her ovaries surgically removed to prevent cancer, throwing her into instant surgical menopause, she can safely take add-back HRT up to age 50.
Wow. And taking that HRT does not diminish the breast cancer risk reduction benefits she gained from the surgery. She gets the protection, and she doesn't have to suffer through surgical menopause in her 30s or 40s.
Exactly. It's a game changer for quality of life.
But we have established this math for prevention, for the general population, and for genetic risk. What happens to the math when we look at someone who has already had a breast cancer diagnosis?
This is where the medical consensus shifts from nuanced to incredibly rigid. The current standard of care dictates that systemic HRT is generally contraindicated for breast cancer survivors.
Just a hard no.
Effectively banned, yes, particularly for women whose tumors were estrogen or progesterone receptor positive.
But why the sudden hard line? If the risk of causing a new cancer is mathematically so small, why is it entirely off the table for a survivor who is suffering?
Because treating an existing microscopic cancer cell that has already proven it can evade the immune system is very different biologically than preventing a healthy cell from mutating.
Okay, that makes sense.
The contraindication is largely based on two conflicting clinical trials that specifically tested systemic HRT in breast cancer survivors: the HABITS trial and the Stockholm trial. Both took place in Scandinavia, but they had drastically different outcomes.
The HABITS trial was the one that basically slammed the door shut, right? They actually had to terminate the study early.
Yes. In the HABITS trial, breast cancer survivors who were given HRT showed a significantly increased risk of their original cancer returning. They reported a hazard ratio of 3.5, meaning the recurrence rate was substantially higher compared to the survivors who weren't given hormones.
Wow.
And another trial called LIBERATE looked at a synthetic hormone alternative called tibolone in survivors, and that also showed an increased risk of recurrence.
But the Stockholm trial happened around the same time, and they found something completely different. Why?
Well, the Stockholm trial found no excess risk of the original cancer recurring. However, they did see an increase in new contralateral breast cancers.
Meaning a totally new primary tumor forming in the opposite breast.
Right. The difference likely comes down to the specific drug regimens used and the specific patient profiles included in the distinct trials. But because the data points to either direct recurrence or new primary cancers, global oncology guidelines play it as safely as possible. Systemic HRT is out.
Which makes total sense from the perspective of an oncologist whose sole job is to keep that cancer from coming back. But let's look at it from the perspective of the survivor. The treatments that save her life, chemotherapy, ovary removal, estrogen-blocking drugs, they often throw her into the most severe medically induced menopause imaginable.
It's brutal.
We're talking about debilitating hot flushes, rapid bone density loss, and excruciating vaginal atrophy.
This raises an important question. If systemic hormones are banned, what options does a survivor actually have to reclaim her quality of life?
The guidelines are clear that non-hormonal treatments have to be the first line of defense. Things like cognitive behavioral therapy or prescribing certain non-hormonal nerve medications that happen to reduce hot flushes.
Right.
But what if those totally fail, and a woman's genitourinary symptoms are literally destroying her life? The British Menopause Society notes that there are exceptions for off-label use of topical vaginal estrogen.
But that exception requires an incredibly careful multidisciplinary consultation with her oncology team, because it depends entirely on the type of adjuvant therapy the survivor is taking to keep her cancer at bay.
And this is where we have to explain the biological mechanism of those cancer drugs. Let's compare tamoxifen to aromatase inhibitors.
That's the critical distinction. Think of an estrogen-positive breast cancer cell like a car engine, and estrogen is the fuel. A drug like tamoxifen works by putting a physical lock on the gas tank.
Okay, a lock on the tank.
The estrogen is still floating around in the body, but it can't get into the cancer cell to turn the engine on. Because the body still has some background estrogen, using a tiny amount of local vaginal estrogen is generally considered safer for women on tamoxifen.
But aromatase inhibitors do something entirely different.
Exactly. Aromatase inhibitors don't lock the gas tank, they blow up every gas station in the state.
Wow.
They completely shut down the body's ability to produce any estrogen from fat or muscle tissue. They starve the body completely. So if a woman on an aromatase inhibitor introduces even a microscopic amount of vaginal estrogen, it is highly controversial.
Because you are basically sneaking a jerry can of fuel back into a town that was deliberately starved of gas.
Right. It could theoretically counteract the life-saving medication. In those severe cases, an oncologist might actually switch the patient from an aromatase inhibitor back to tamoxifen just so she can safely use a vaginal estrogen ring.
That is such a delicate balance. So what does this all mean? We have journeyed from the global panic of 2002 to the intricate mechanics of cancer cell engines. If we synthesize everything we've told from these sources for you, HRT is absolutely not the boogeyman that the press made it out to be 20 years ago.
Definitely not.
If you take estrogen-only therapy, you might actually be triggering apoptosis and lowering your risk of breast cancer mortality. If you take combined HRT, there's a slight absolute risk increase, but mathematically it is roughly equivalent to the risk of carrying extra postmenopausal weight or enjoying a couple of glasses of wine. And if you opt for modern bioidenticals like micronized progesterone, that risk shrinks even closer to zero.
The ultimate takeaway is that evaluating HRT requires looking at absolute numbers, not relative panic. You are balancing a remarkably small statistical risk against what can be immense life-saving quality of life benefits.
It is your health, your body, and your choice based on biology, not clickbait.
But before we wrap up this deep dive, there is one final, incredibly provocative statistic from the data that forces us to reframe this entire debate. We spend so much time hyperfixating on breast cancer.
We really do. But when we look at the mortality data from 2017 in England and Wales, the number of postmenopausal women who died from ischemic heart disease to osteoporosis combined was almost 4 times higher than the number of women who died from breast cancer. 4 times higher. That is a massive difference.
And we know definitively from the literature that when HRT started early, around the onset of menopause, it significantly protects the cardiovascular system and prevents bone fractures.
Right.
Which leaves us with a critical, almost uncomfortable thought to mull over. Could avoiding HRT out of an inflated fear of a microscopic breast cancer risk actually be increasing a woman's overall risk of premature death from the conditions that are statistically far more likely to kill her?
It is a profound question. We spend so much time staring at the shadow in the corner of the room that we completely ignore the massive structural cracks in the foundation right under our feet. Understanding the biological mechanisms gives you the power to turn on the lights and see the whole room clearly. Thanks for joining us on this deep dive. We'll catch you next time.